This presentation will cover an introduction into renal replacement therapy when used on critical care. So we're going to talk about the indications for RRT, a bit of basics about how it works, when to start it, what an effective dose is, comments around access, meaning which lines we should use and where, and we're going to discuss citrate anticoagulation. So indications for renal replacement therapy on critical care, we talk about emergency indications, as in this is different from intermittent hemodialysis used in the community for stable long-term renal failure patients. We're initiating this for a particular reason. So indications that we might start renal replacement therapy on critical care would be things like symptomatic uremia, hyperkalemia, refractory acidosis, refractory fluid overload, specific management of drug overdose or toxicity, in particular lithium, salicylates, toxic alcohols like methanol, methylene glycol, and theophylline toxicity. Other less common reasons to use it would be temperature control. Using an extracorporeal circuit is a very effective way of adjusting the patient's temperature, particularly in hyperpyrexia. Sepsis, although this has fallen out of use more recently due to less evidence around the use of it in this setting, but there was a vogue for a while of using high-dose hemofiltration to essentially try and filter out all the cytokines to reduce hemodynamic instability. And then correction of electrolyte abnormalities such as hyperkalemia we've mentioned, but you can use renal replacement therapy to slowly correct hyponatremia, for example. Staging of AKI, the most commonly used staging system is the KDIGO classification, which classes AKI from stages 1 to 3. And again, this is useful when seeing a referral that's in renal failure to classify how severe their AKI is. Once on the critical care, once established in renal failure, we tend less to refer to these stages and more to look at trends in the creatinine, monitor the urine output, and monitor for any indications for commencing renal replacement therapy. The circuit. This can be used as an intermittent mode or as a continuous mode. So intermittent hemodialysis would tend to be used on stable renal failure patients, for example, in hospital dialysis units, or for stable patients in the community attending for their regular dialysis, or as a continuous mode in patients that are more critically ill on intensive care. Blood is passed through a filter that goes past the semipermeable membrane, and in a countercurrent direction dialysate will flow against this membrane, and solute clearance is achieved by diffusion, predominantly driven by the concentration gradient. So the end composition of the blood will be determined by the dialysate. Hemofiltration is a common mode of renal replacement used on critical care. Here, blood is pumped past the semipermeable membrane under pressure, which causes water to pass across the membrane, and via solvent drag enables solute clearance. The resulting blood is more concentrated, so some replacement fluid will need to be given. The volume of this replacement fluid that is given, as compared to the amount of ultrafiltrate removed, will determine the fluid balance. If we're giving less replacement fluid than there is ultrafiltrate, this will result in a negative fluid balance and fluid removal. If we're giving the same amount of replacement fluid as ultrafiltrate, this is what we refer to as straight exchange, and means we're not taking any fluid off. The composition of the replacement fluid can be altered. Mainly the concentration of potassium can be either 2 or 4 millimoles per litre, and this will allow us to control potassium when it's high. Where in the circuit the replacement fluid is given can also have an effect. So we tend to give the majority of the replacement fluid post-filter or post-dilution, and this enables maximum efficiency of the filter. If we're having issues with clotting of filters, we can give the replacement fluid pre-filter, and therefore the blood is more dilute as it passes through and less likely to clot. In terms of choosing between hemodialysis and hemofiltration, there's limited evidence to guide our decision in choosing between the two, and often in most units it tends to just be local equipment availability and usual unit practice to do one or the other. There are some differences between the two. So in ultrafiltration, larger solutes can be removed up to 15 to 20 kilodaltons, and this is due to both ultrafiltration of the molecules but also adherence of the molecule to the filter, whereas dialysis will tend to remove smaller molecules. There are always changes in size of the filters, the pore sizes, etc., that often means that some filters behave differently to others. The other thing that's different is the rate. So the rate of fluid removal and the subsequent osmolar shifts will affect the cardiovascular stability. So if we use intermittent hemodialysis in an unstable patient, they often will become even more unstable during this. There's also such thing as the rebound phenomenon if rapid intermittent technique is used. So for example, in lithium toxicity, where the lithium is widely distributed across the body, if you do a rapid intermittent technique and remove all the lithium from the intravascular space, there will be a rebound where the lithium will reaccumulate due to equilibration across body compartments. And there's also some suggestion that in critically ill patients there is more risk of brain edema due to osmolar shifts in intermittent hemodialysis. Looking at the literature, choosing between continuous modes of hemodialysis versus hemodiafiltration, which is essentially dialysis, but the blood is under pressure, so there's also ultrafiltration that occurs. Therefore you get solute removal via diffusion down a concentration gradient and solute removal via ultrafiltration. There's no evidence of better outcomes by either one, so they're seen as equivalent. Practically, there'll be some differences in terms of the frequency of bag changes for fluid removal and replacement that will be needed, with it being much more often in hemodiafiltration. And there's also some practical things that means we tend to use HDF in select cases such as fulminant liver failure. Now, a lot of that is due to local practice. In that hemofiltration, we would use citrate as an anticoagulation, which we tend to avoid in fulminant liver failure, whereas hemodiafiltration we may use either without anticoagulation or with heparin. But in theory, the clearance using 1 ml of dialysis is the same as the clearance using 1 ml of filtrate, so they should be the same in terms of clearance. So looking at the actual circuit and what it's composed of, there are 2 patients on this. Obviously they are the same patient because it is a circuit. The blood is leaving the body, going through the filter and being returned to the patient, and then there is some waste removed, i.e. the ultrafiltrate. There are some pumps in the circuit which are represented by these circles, and there is an access pump that pumps blood through the filter from the patient. And there's also a pump that will pump the waste away from the filter. Adding in some more things to the circuit, there is an anticoagulant added pre-filter. Now this may be heparin, this may be citrate, and there are a few others less commonly used. And depending on the type of renal replacement you're using, there may be dialysate pumped in a countercurrent direction under pressure, for example in hemodiafiltration. Now there's pre and post dilution replacement fluid, which again are given into the circuit under pressure. The ratios of pre to post dilution will determine your filter efficiency. So if we're giving more fluid pre-dilution, that will reduce the filter efficiency because the blood passing through the filter is more dilute. However, it will be much less likely to clot. Usually we would give the majority of the fluid post-dilution. There are also some pressure detectors that prevent pressure overload, and they make the alarm go off incessantly when it detects a negative access pressure, which is a common sign that the patient is either hypovolemic and you're getting venous suck down onto the line, or the line is in a poor position. There's a heater, which allows us to control the temperature of the circuit. There's a bubble trap and bubble detector so that we're not giving inadvertent air emboli. There's also a blood leak detector, so if there's blood running onto the floor, there should be an alarm goes off that tells you. And there's scales. We allow the machine to know when the waste bag is full. The next thing we'll talk about is actually delivering the ROT and the dose that we would use and the timings. START AKI was a very informative trial for starting renal replacement therapy in critically ill. They randomised almost 3,000 patients admitted to ICU with AKI with severe renal failure, either stage 2 or 3 of the KDIGO classification. And they excluded them if they were deemed to need urgent renal replacement therapy. And essentially they compared either giving them early renal replacement therapy or delaying renal replacement therapy until they reached what we would consider an emergency renal replacement therapy indication. So in the accelerated group, nearly all of them got renal replacement therapy, whereas in the standard group, where we were delaying starting it, only 61% got renal replacement therapy. And the 90-day mortality was identical, so there was no difference between the two groups. And in terms of survivors, there were less survivors that were dependent on renal replacement therapy in the standard group, and much less adverse events in the standard group, because obviously we're not using renal replacement therapy with all its problems of low blood pressure, electrolyte abnormalities and arrhythmias, and also they're going to have less lines put in, so less risk of catheter-related bloodstream infection. So we initially give renal replacement therapy for hard indications that we've already discussed, the emergency indications. We don't tend to start it early without a good reason, because there's no benefit. This has changed over the years in that there was a time when we would give renal replacement therapy earlier and with a higher dose. The idea being that high dose renal replacement therapy in septic shock might reduce the amount of circulating cytokines and other bad things in the circulation and therefore make the patient better. But there's no evidence that actually is true or improves outcomes. Now though, with more and more evidence that delaying renal replacement therapy until we actually need it is a good thing, we tend to limit it. So we would limit it to a minimum dose. We'd be more relaxed about starting it without a hard indication. For example, one of the emergency indications we've also talked about. We're reconsidering more and more bicarbonate, in that perhaps bicarbonate supplementation can improve acid base and delay the requirement for renal replacement therapy. And there's more and more thought about, are we actually causing harm with renal replacement therapy? Are we impairing the kidney's ability to recover by providing this treatment? What dose? So dose of renal replacement therapy is essentially the volume of ultrafiltrate that's being removed. That's referred to as the dose. And that would be prescribed in mils per kilo per hour. There is probably a limit below which harm will be caused. So obviously if we're not doing enough dialysis, this will cause harm. There's probably a happy ground. So the minimum probably is 20 to 25 mils per kilo per hour, roughly. There doesn't seem to be any evidence to go higher than this. In the trials, we could see that the urea usually is less than 20 in both arms of the trials, whether you're giving a high or a low dose. So therefore, they're probably adequate. The only reason really to prescribe higher doses is to ensure that dose is delivered. So if I prescribe a higher rate, for example 35 ml per kilo per hour, then probably in reality the patient will receive closer to 25 due to breaks in the therapy for trips to scan or issues with the line, or delays starting it, there tends to be a difference between the received and the prescribed treatment, which may be why we would prescribe a higher dose to start with. So location for the line. The preferred site for hemodialysis catheter or an HF line is the right internal jugular vein. This is a nice straight line to the right, towards the right atrium, with minimal kinks and bends, and it's less likely that a part of the vein is going to set over the lumen and cause suck down and low access pressure. The second choice would be the femoral veins. The difficulty with this is that there's probably more recirculation of blood, so you're more likely to be sucking the blood back into the filter that's just come out the filter. So sucking blood coming out of one port of the line and going back into the other one, and this is going to massively reduce your efficiency of dialysis. The third choice would probably be the left internal jugular vein. This is a longer course with more twists and turns towards the right atrium, and it's much more likely that the tip of your catheter will end up against the vessel wall. Now, historically, this was a big concern in terms of causing perforation of the veins, particularly when the old catheters were very stiff. They're now a lot softer, so that's less of a worry, but they will malfunction if there's a vessel wall being sucked down into the catheter. And then lastly, the subclavian would be the final choice, and the reason for that is there is a risk of causing venous stenosis from these large catheters, and that seems to be highest in the subclavian vein. So if you cause stenosis of the subclavian vein, the patient is not going to be able to have an AV fistula on that side if they should need it in the future. The other thing to think about is if they're a transplant candidate causing stenosis and issues with the femoral vein, or the catheter tip causing issues higher up, this is where the transplant kidney is going to be plumbed in. So again, that can cause issues. The length, so the right IJ line will be the shortest. We tend to have 15 centimetre lines, which tends to be perfectly adequate. A left IJ line will have to be slightly longer, and in the femoral, the longer the better, to avoid recirculation. The Cathedia study looked at infection risk related to line position, and it suggested that there was increased infection risk for femoral lines if the patient was obese, and increased infection risk for jugular lines if the patient wasn't obese. But overall, the marker wasn't terribly clear, and it didn't find that overall there was an increase for femoral catheters of other complications when put all together. For all lines, though, it did find that there was a linear increase in infection rates with time since insertion. Now, there's sort of an international standard advice that we don't routinely change the lines after a certain length of time, for example 7 days, but certainly I'd be keeping a close eye on any line that was around 7 days or older for any evidence of infection, at which point I want to remove it. The urea reduction ratio, which is the URR, which is a marker of efficiency of dialysis, is lower if the femoral catheter is shorter. So this would imply more recirculation and less efficiency, so we tend to use a longer femoral line. When to change lines? Well, the thing we want to avoid here is a catheter-related bloodstream infection. There are some units that would commonly preemptively change based on time criteria, for example 7 days for a central line. The USA CDC guidance suggests that there'd be no routine line changes without reason, and same for the EPIC-3 study. Just generally in the literature, they've found that routine changes don't have any effect on the rates of catheter-related bloodstream infections, and you're more likely to have mechanical complications related to more lines and more vessel punctures. But it's important to do a daily line review, so inspect the line every day, and if there's any suspicion of infection, we need to change it. Usually this means getting changed around between day 7 to 10 on ITU, because a patient will usually have a fever for some reason, and if you've got a day 9 line and the patient's pyrexic, we need to be thinking, is that coming from the line, and think about getting that line out. Practically, in general, we've moved towards putting a standard central line into the left IJ when we think there's a reasonable chance the patient might need renal replacement therapy. This is to save the right IJ for a right-sided HF line. So if a patient comes in and needs a central line, they're in renal failure, it's a good idea to put the central line in on the left. We also quite like the HF lines that have 3 lumens. What this means is you've got 2 big lumens to perform hemofiltration or hemodialysis with, but there's a smaller central lumen that you can use as a central line. So sometimes if a patient needs hemofiltration, but they only have requirement for 1 central drug to be given, you can get away with just with a 3 lumen HF line rather than a central line and an HF line. It's important when you're putting these dialysis lines in that you check that they're working adequately. So once the line's in place, you want to see that you can rapidly aspirate blood into a 20 ml syringe from both lumens. And the flow rate roughly is that you need to be able to get 20 ml easily into the syringe in less than 6 seconds. With a good working line, you should be able to get 20 ml into the syringe in less than 2 seconds, really. If you find that you can't aspirate quickly when the line's first in, there's a high chance this line isn't going to work very well. It's unlikely to fix itself. Citrate. So citrate is recommended as an anticoagulant for renal replacement therapy by the KDIGO guidelines, although admittedly this is on fairly thin evidence because there's no clear difference in mortality when comparing to using heparin as an anticoagulant. But it is fairly consistently, both anecdotally and in the evidence, that your circuit will last much, much longer. So often a heparinized circuit will clot, and it can be difficult achieving the APTT ratio targets that you want to achieve. Whereas citrated circuits they very, very rarely clot. It also is regional anticoagulation, so you're anticoagulating the circuit and not the patient, so it avoids the risk of anticoagulation in patients who might have a bleeding risk. In the dark ages before citrate, when there was mainly heparin used, this basically resulted in hugely individualized renal replacement. So every unit did it differently. Every patient had a different approach to renal replacement. There wasn't any majorly standardized approach, and the prescription had to be very, very detailed, and it had to specify all possible parameters, and often it was filled in by the least experienced person available. There are also some bizarre approaches to heparin, as in giving massive boluses or giving no boluses, or just failing to achieve any reasonable APTT ratios. And as a consequence, the circuit survival was very poor. You're generally looking at the circuit lasting less than 12 hours before it clots off, which obviously is going to reduce the amount of renal replacement received, reduce the efficiency. And also if the circuit clots when it's full of blood, then that patient's going to lose that blood volume, and over time they will become more and more anemic as a result. So the aims with introducing citrate was that we would standardize practice. We've reduced the nursing skill requirements by making the approach very standardized and intuitive, and therefore reduce the workload, and hopefully allow us to deliver the therapy with lower blood pump speeds, a longer circuit survival, all while avoiding bleeding complications and keeping costs down. So I don't expect you to remember all the components of all the different constituents of the replacement fluid and the citrate we use. But it's just worth highlighting how different to plasma the fluids we're using are. Therefore, if we do it wrong, there's a high risk of concentration. We're giving lots of citrate, we're giving lots of calcium. The dialysate we're using is wildly different to the serum levels that we would tend to see. So if it's done wrong, it can cause problems, which is why a standardized approach is needed. So here, as we can see, we're putting concentrated citrate in pre-filter. This is going to collate all the calcium in the blood and stop it clotting. Then at the other side of the filter, there's replacement calcium added to restore that calcium. Now that citrate calcium complex that's formed by adding citrate pre-filter is going to be largely filtered out into the waste fluid. So it's not all going to be returned to the patient. There will be some that's returned, and the small amount that's returned will be metabolized into bicarbonate, therefore allowing us to have some replacement fluid, replacement base. So this is taken from a citrate HF prescription, and again, I don't expect you to remember all these values, but the dose that we're giving is in the left-hand column, and with each one there is standardized blood flows, dialysate flows, citrate flows, and what this means is that we're giving the correct citrate delivery to the patient. So no one should be altering any of these settings in isolation. They all have to stay in the right ratio, otherwise it won't work. So like I said before, citrate is metabolized to bicarbonate by the liver, and this means that the replacement fluid doesn't have to contain a buffer such as bicarbonate, because the patient's going to generate their own. It does mean that the more citrate that goes into the patient, the more bicarbonate they'll generate. So here, as we can see, the blood is being removed from the patient through the red lumen here. Citrate is being added. This is going through the pump and through the filter. There's an effluent. So this is the waste product that will contain citrate calcium complex. And then the dialysate will include the replacement fluid in HDF. This is then going to go back into the patient once calcium has been added. So the citrate calcium complex is returned to the patient in small quantities. And again, this is just a picture to represent where the constituents go. So the citrate is added pre-filter. In the filtrate, there's all the things we don't want, as well as some of the citrate calcium complex. We're also filtering out quite a lot of bicarbonate there, so the patient is going to need some buffer returned. The calcium is added post-filter, and then the blood is returned to the patient. So in a patient that's having too much citrate accumulation, you'll have low total ionized calcium because the citrate is collating all the ionized calcium. But if you measured the total calcium, it will be high. So the total to ionized calcium ratio is important to measure when looking at citrate accumulation. So just a quick slide about things that can affect citrate delivery to the patient. So there's an increased diffusion gradient, i.e. there's more citrate calcium complex on one side of the filter than the other. This will enable more efficient removal of citrate and therefore less being delivered to the patient. And again, if there's an increased ratio of dialysate to blood flow, so we're using HDF with the higher dialysate flow, this is going to increase the gradient and again allow citrate removal. Then if there's an obstruction to the filter, so for example the filter starting to get clogged up, this is going to be less efficient at removing citrate calcium complex, so therefore more is going to be returned to the patient. So there's two main problems here that we see with these citrate calcium complexes. One is where we have citrate overload, and here the citrate calcium complex are getting to the patients more than they should be, but all of them are being metabolized, and what this means is you're generating an awful lot of bicarbonate, whereas actually your calcium levels will remain normal because there's no free citrate. As this goes on, when the filter starts clogging, removal of this complex becomes less efficient, and gradually you see the bicarbonate rising. And the only way to fix this is to change the filter. There's no other way of fixing it. You commonly see this in patients who are very septic, who have a lot of other proteins flowing around in the blood, like inflammatory mediators. And then the other problem is citrate accumulation. So here, the liver is unable to metabolize citrate. So you have free citrate floating around in the body. And what this means is you have low ionized calcium because the citrate's removing it all. And this will cause an increased TI ratio, or total to ionized calcium ratio. And over 2.5 is where you want to start to worry. So this can be very serious. You can have cardiovascular collapse from symptomatic hypocalcemia. You can develop metabolic problems such as acid-base disturbances and lactic acidosis. So the treatment is to stop giving citrate and to restore the calcium quickly. So just some general points about citrate accumulation. So the only slight problem with all this is some of it's theoretical because we don't measure citrate in the body. We're just inferring that it's high because we're seeing low calcium, because we're seeing other problems. However, if you start the patient on renal replacement therapy before correcting the ionized calcium, so if they start with an ionized calcium that's low, then you're not sure whether you're just trying to catch up or whether they actually do have citrate accumulation. So it's very important that the calcium is corrected before commencing renal replacement therapy. Liver failure is not generally a contraindication. It's very common to accumulate, very uncommon, sorry, to accumulate citrate. We just need to monitor it very carefully. There's also some suggestion that citrate elimination is oxygen dependent and partially extrahepatic, so it may be that liver failure isn't a complete contraindication. And there's probably an association between impaired citrate metabolism in multi-organ failure with 100% mortality. So if you're at the point where you're unable to metabolize citrate, your outcome's probably going to be very, very, very bad. And there's various algorithms to deal with citrate accumulation. This is all on the prescription charts for citrate HF, which is worth looking over just to familiarize yourself with.